Hi, welcome to this virtual tumor board. I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine and the clinical director at the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. We have a wonderful panel today, a multidisciplinary approach discussing 9 cases. We'll start with introductions, and Dr. Force, if you want to start.
Sure. I'm Dr. Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of General Thoracic Surgery at Emory University Hospital in Atlanta.
Thanks, Dr. Force. Moving around the Zoom room, Dr. Kamich.
Hi, I'm Dr. Ross Kamich. I'm Director of Thoracic Oncology at the University of Colorado Cancer Center. I'm a medical oncologist where I hold the Joyce Seth Chair in Lung Cancer Research.
Great. Next, Dr. Higgins.
Hi, I'm Dr. Kristen Higgins. I'm a radiation oncologist. I specialize in thoracic malignancies at Winship Cancer Institute of Emory University.
Great. And rounding us out, the radiologist, Dr. Keys.
Hi, my name is Dr. Darren Keys. I'm a diagnostic and interventional radiologist for Piedmont South Imaging, covering Piedmont Fayette Hospital and Piedmont Noonan Hospital, south of Atlanta.
Great. All right, Dr. Kamich, walk us through this case.
So, 68-year-old Caucasian male, previously well, never smoker. He worked in the Air Force and then he became a Christian missionary for about 20 years. And he had some travel to foreign countries, but never any prolonged stay. He developed a non-productive cough in the fall of last year, 2019, and then that's worsening, so slowly worsening. But of course, COVID arrives, so he puts off working it up. By the time May arrives, he's lost about 25 pounds in weight. He goes to his primary care physician, the cough is getting worse, and he's starting to develop some pleuritic. So pleuritic means stabbing kind of pain when you're taking a deep breath in or coughing in his left upper chest. PS0 means performance status 0. That means he's still pretty fit. He has no significant past medical history apart from some cholesterol issues, and he's on a statin, that's for his cholesterol, and Robitussin for his cough.
Okay.
His primary care does a chest x-ray and it shows some calcified, so that means literally deposits of calcium, almost like stone in the lymph nodes in the middle of his chest. He gets a CT scan, which shows at the top of his left lung, there are some masses that shouldn't be there. You can see those lymph nodes rather more clearly in the middle of his chest, and there's some calcium in them. There's some calcium also at the bottom of his left lung, his left lower lobe. There's a little nodule, which is calcified. Lymph node that's between where the airway splits in two was sampled at a bronchoscopy. And it showed this thing microscopically called rare non-caseating granulomas. Now, what does that mean? A granuloma is a microscopic inflammatory focus. So some inflammatory process is going on. A non-caseating means the middle of it hasn't turned literally into a cheesy-like mass. Why does that matter? Caseating granulomas are one of the features associated with tuberculosis. Non-caseating granulomas opens up a whole nother differential diagnosis, including a condition called sarcoid, which we don't really know what causes it. It looks a lot like tuberculosis, but there's no organism. The treatment for sarcoid is steroids, and so he went on a 6-week course of prednisone under an assumptive diagnosis that this was all sarcoidosis.
Great.
So Dr. Keys, do you want to talk through these scans? So these are the pre-steroid scans when he was first diagnosed.
Yes, thank you. So we've got 4 CT images here. The image on the top left is an image just at the level of the carina, and this is in lung windows, so you can see the lung tissue. There's an arrow pointing at a lymph node underneath the carina that has calcium. It's a little hard to see with the windows, and we'll look at that further, but there's a calcified lymph node. But within the lung parenchyma itself, there are several irregular mass-like areas of consolidation just in front of the hilum of the left lung. And these areas extend out and are also abutting the pleural surface of the lung. There's some areas where the actual interstitium of the lung looks thickened, and that's signified by the very top blue arrow. There's also some nodules in the lung that have spiculations on them. Following that up with the image below, this is an image just taken a little bit higher, where you can see these calcified lymph nodes in the paratracheal area, but also there's a lymph node just adjacent to it that's enlarged, it's somewhat rounded in appearance, and it is not calcified. Looking further down in the abdomen on the top left image, you can see these tiny little speckles of calcification in the spleen, and you could see a calcified nodule in the left lung base. And then the image on the bottom right shows more of these splenic calcifications. These are important because in many regions of the country, this is a common finding. Little tiny, what we call calcified granulomas that you can see in the liver, the spleen, and oftentimes in the lung. If those are associated with calcified lymph nodes, that's commonly just something that can be due to a prior, what we call granulomatous disease. It's basically an asymptomatic infection that you've had before in your past, and not too much comes of it. However, when that's taken into account with the findings seen on the image on the top left, this appears like a more aggressive process. The enlarged non-calcified lymph node is also somewhat suspicious. And the differential for this would include both inflammatory and neoplastic conditions, including sarcoidosis, including adenocarcinoma of the lung.
I think we have some additional images here.
Yeah, so these are the scans that were done after 6 weeks of steroids.
Okay. So 6 weeks after treatment, what you would hope to see if this was a benign inflammatory condition is you'd hope to see some improvement in the appearance of the chest. These are axial CT images. These are just above the level of the carina. The image on the left is performed without intravenous contrast, and the image on the right was after the administration of intravenous contrast. You can see all of the vessels now are bright white, and that's from the iodine within the contrast. There is a lymph node that it looks like it's enlarged since the prior study, and that's just a paratracheal lymph node just above the carina, and it looks like it enhances a little bit. It doesn't have a normal lymph node shape. And this aggressive appearing process happening in the left upper lobe, extending from the hilum all the way to the pleural surface, it looks like it enhances. There's areas of soft tissue thickening that extend along the interstitium of the lung. And again, the differential for this would include still both benign and malignant processes. But given these findings and given the response to steroid treatment being less than optimal, I would be suspicious for this being a lung cancer.
Great. I think we have a few more images.
Yes.
The image below is the same image, just in lung windows, which kind of helps show the changes in the parenchyma a little bit better. You can see there's a few satellite nodules that are developing around this area of abnormality in the left upper lobe. You can see a few what are called bronchograms, which are just air-filled or airways within the lungs that are otherwise consolidated with soft tissue that are filled with air. Again, somewhat of a non-specific appearance, but again, the differential would be about the same.
Okay. And then
final image, this is called a maximum intensity projection, which we just call a MIP for short, of a PET CT. And this is like you're looking at someone in the mirror, or if the patient's looking at himself in the mirror, where you can see, you can kind of make out the spine and the midline and the liver and the right upper part of the abdomen. There is some physiologic uptake that happens with PET scans. You can also see the brain is very bright because the brain uses glucose for energy. But what you notice in the mid portion of the chest are multiple small areas that are very, very intensely avid. And these correspond with the findings that were just described on the CT of the chest. The largest part reflects the abnormality within the lung parenchyma itself, and these smaller little areas of increased uptake probably reflect the lymph nodes within the chest.
Great.
There's also a tiny area of uptake down in the pelvis that corresponds to the bone lesion in the patient's iliac bone.
Great. So Dr. Kamich, continue here.
Yeah, so that, Dr. Keith, that was a fantastic summary of the imaging. So absolutely. So he goes on the steroids, and two things happen. The stuff in the lungs gets worse rather than better, and the lymph nodes, the sort of non-calcified bit of the lymph nodes, also get worse. He gets the PET scan. It's as you described. And then in addition, outside of the chest, there's that lesion in the bone of the pelvis. So it's still kind of like, well, we don't quite know what's going on. So he actually goes to a surgeon. So the surgeon feels that the easiest way to get access to this, and Dr. Force can chime in as to whether he would have done the same thing, was to do a VATS procedure, video-assisted thoracoscopic surgery, and they did wedge resection, so little slices of the pie of the left upper lobe. They only got benign inflammation, but they did take out what was called an AP window lymph node. So that is aortopulmonary window. That is a lymph node sitting near some big blood vessels at the time of that surgery, and that, hey presto, did show adenocarcinoma. TCF1 and CK7 are two of the immunohistochemical markers, the stains that can show this is coming from a lung. It has very high expression of something associated with response to immunotherapy called PD-L1 at 90%. And the molecular testing was done, and there's a specific driver mutation called a KRAS G12V mutation. We talked about the results of the PET scan. He also got a staging brain MRI, which was clear. The plan was that they were going to be started on some systemic therapy, and they're going to have a port inserted. And at the time it was put on, he's noticed his sort of left leg got itchy, and he had a superficial saphenous vein thrombosis. Again, some kind of inflammatory process going on. Remember, he also had the weight loss.
Incredible case. So many questions, so little time here. I briefly want to just, Dr. Force, your approach to something like this, would you have done the same thing with wedging out the left upper lobe and at the same time removing the AP window, or would you biopsy the AP window to try to define what this is? Just in 20 seconds or less.
Sure. So I'll try 20 seconds. So it would depend on the PET scan. Historically, the standard approach to biopsying mediastinal lymph nodes is a procedure called a mediastinoscopy, where lymph nodes around the trachea can be biopsied. That's mostly been replaced by a less invasive procedure called a bronchoscopy with endobronchial ultrasound and biopsy, which can be done as a needle biopsy, no incisions. The AP window is where the pulmonary artery to the left lung crosses behind the aorta. That cannot really easily be accessed by either of those two techniques. So if that's the only lymph node lighting up, then the VATS is the appropriate approach. If there was a left paratracheal node lighting up, we probably would have done an EBUS, a bronchoscopy, and biopsied that. So yeah, I think that taking out that lymph node got the diagnosis, and at least the staging, minus the iliac bone lesion, it makes it a more advanced stage cancer.
So Ross, the AP window node is positive, but there's nothing really from the lung, at least on biopsy. Where is this coming from? Is this just a lymph node only lung cancer, or is there a parenchymal mass associated with this, a lung mass that this came from? Any thoughts on that?
So I think what we're really seeing here is that, he clearly has a lung cancer. It has clearly spread to a lymph node. That lymph node is technically called an N2 node, so that's considered in the middle of the chest on the same side. What you can see is there's this overlying inflammatory condition that may have been a kind of infectious thing, with the weight loss, with the superficial clots, with the calcified lymph nodes. And my guess is there's probably a lung cancer buried somewhere in that left upper lobe, but there's so much inflammation around it that those wedges, which are not a lobectomy, they're just a sample, have somehow missed it.
Got it. Go ahead.
Well, the real question is, What is the true stage of this cancer?
Yeah, well, that was my next question. This brings into the fold probably a 45-minute discussion on the management of oligometastatic disease, or otherwise known as, you have a lung cancer in one area of the lung, but you also have an isolated focus of metastases, at least evident by PET scan. You want to take us through what you think here in terms of how you would approach this in this patient?
Well, so you've hit the nail on the head. So the real question is, we know this is at least a stage 3 cancer. That's what a cancer that spread to the lymph node in the middle of the chest is. But we have this one focus outside of the chest, down in the pelvis, in the bone there. So we can either assume that is whatever the inflammatory condition is and nothing to do with the cancer, or we can assume it's something to do with the cancer, and therefore this is metastatic disease, although technically oligometastatic because it's the only sign of disease. And so the question is, do you go chasing down all these biopsies with, we've had some perhaps false negatives on the biopsies before, or do you give them the benefit of the doubt and treat it like stage 3, or do you, prepare for the worst and treat it like stage 4? I can tell you what I did.
Yeah, please.
So, you have to try and decide what is the biggest sin. And I feel the biggest sin would be to underestimate the true stage. And so I felt we should start with systemic therapy and then keep an eye on this. So if the systemic therapy produces a differential response in different places, that would be a big red flag that maybe there's a different process going on. So let's say the lungs all got better, that stuff in the bone stayed exactly the same. I then go biopsy it because I think maybe something else is going on. If they all shrink down together, I probably feel more confident this is stage 4. And then what I might even do is I might even go to Dr. Higgins and say, look, We've had a great response. We've had several rounds of treatment that we've taken it to as much as we can. Can you help me out and tidy this all up with some radiotherapy?
Dr. Higgins, to you, let's say Dr. Kamich does give immunotherapy-based treatment, and we can talk about whether it would be single-agent immunotherapy or immunotherapy plus chemotherapy for a PD-L1 greater than 50%. But Dr. Higgins, the patient comes to you after 4 cycles or 6 cycles, and everything looks to be stable and both or even shrunk from the AP node and the bone. Is there a role for radiating 1 or 2 of the spots?
So there have been 2 small phase 2 trials in the United States that have looked at this exact scenario and asked the question, do patients benefit from aggressive radiation to the primary as well as the sites of metastatic disease? And both trials showed a strong improvement in progression-free survival. Now there has not been a completed large phase 3 trial with a overall survival endpoint yet to show that giving that definitive radiation does in fact make our stage 4 patients live longer. But I can tell you that there is a trial in North America testing that approach right now. It's called NRG Oncology LU002. So most of the time when we have patients in this scenario, we will try to enroll them in that trial where they get randomized to just the continuation of the systemic therapy versus SBRT to the bone lesion to the primary site of disease, followed by the maintenance therapy. I will say that I tend to use MRI to fully define the extent of bone lesions in particular before giving SBRT, because sometimes I think that on PET scan, they can be underestimated. And certainly if I'm giving an ablative dose of radiation, I want to make sure that I'm covering the entirety of the tumor.
Okay, great answers. I wish we could spend more time on this because this could go on for quite a while. The management of oligometastatic disease, oligo meaning very few sites of disease that are outside the primary lung area, and how to manage these patients has evolved rapidly over the past even 12 to 24 months and how we manage these.